Hello, everyone. This is a presentation for ECR concerning fusion ultrasound, a luxury which is becoming a necessity. My name is Alexis Kelekis. I'm a professor of diagnostic and interventional radiology. As disclosures, I have to accept that I'm consultant for Mindray Medical on fusion ultrasound, and this talk is provided by Mindray Medical. This is my hospital, which is an 800-bed hospital, university hospital at the outskirts of Athens. If we talk about fusion imaging and interventional procedures, there are a couple of current limitations. First of all, ultrasound lesions may not be visible or may not be accessible. They are highly operator dependent and have poor global visibility due to the effect ultrasound does. CT, on the other hand, has radiation exposure, which is exponential if you do multiple takes. An off-axis approach can be troublesome. Lesions are transiently visible with contrast media, and MR, although it's better, is not always available. It's complicated as a procedural environment, and of course, it's costly. Now, what do we want from fusion imaging? The fusion imaging must enhance the images produced by ultrasound scanners and combine them with another modality and have these images available in real time. With that, we can have a defined organ conspicuity. We can confirm the contrast uptake and follow it up. We can delineate and approach a lesion directly where we want. Also, when we do an ablation, we can confirm the pattern that we ablated, and we're going to discuss about those issues. Now, different imaging modalities could be used with interesting real-time modalities, such as ultrasound, and thus enhance the localization capabilities. What we usually do as interventional radiologists or radiologists, we mentally do fusion, which is called a cognitive fusion. We keep the images in our head and combine them with what we see, and we try to melt those two images in our mind. What we want to do, we want to do that mechanically. We want to have that on screen by an automatic co-registration, overlapping and having a simultaneous display. So the idea is to have a non-intrinsic real-time modality, such as 3D CT or MRI acquisitions, and then have the real-time modality, the ultrasound, and bring those two volume of images together to create a co-registration. And that will help us have an interactive localizing modality. Now, the procedure can be done to detect lesions through CT, MRI, or PET, which are inconspicuous to ultrasound. So at this time, we just use the ultrasound as the locator device. We can suggest the best scan approach to better identify a target when we have multiple approaches, and can easily drive the operator in the region of interest. The ideal system should be accurate, should allow motion correction in real time, should be consistent in any section plane, and of course, should be reproducible among all skill levels and be user-friendly. Now, the steps in order to perform a fusion imaging is to load first the images that we want from the dataset, whether that's a dataset of CT or MRI, or it can even be a contrast-enhanced ultrasound dataset. Then we place a marker, which can be optional, on the target that we want to attain. And then we do the image registration and fine-tuning. Sometimes when we want to do respiration compensation, we can take a cine loop, capture that cine loop, and use that, and we're going to explain how this works. Then we can have the real-time combined scanning and the navigation. When we're talking about respiration compensation in a 3D model of liver, then we acquire the whole image using a cine loop with a fixed probe position. The system selects the cycle which is best represents the motion. And then we select a tracking region using a ROI, where this is where we want to attain. The system automatically analyzes the tracking results in 3 dimensions and then builds the 3D models of the liver movement due to respiration. So actually the system follows that point and creates a 3D volume in total. These are images of this type of videos. On the left, you can see without their compensation, the image of the liver moves differently on the CT and differently on the ultrasound, thus creating a misregistration. On the other hand, when you have a registration compensation, you can see that both borders follow together and both vessels follow together without that blurring that can be created by the respiration compensation absence. So this kind of co-registrations allows the elastic deformity of the CT scan to follow the ultrasound imaging. Why do we use fusion imaging? Because as we said, lesions can be best identified sometimes with CT, MRI, or PET, or contrast ultrasound. Sometimes lesions are not at all seen under ultrasound when are visible with other modalities. Or lesions are only seen after contrast uptake. So you inject the contrast and then you see the lesion, which is occult in its original form. Sometimes when we do an ablation or a treatment, the lesions can be hidden during that treatment, which means that they are gassed out by our ablation system. Composite ablations sometimes require multiple needle insertions and complex geometries of difficult location plans. So in these cases, having a fusion imaging will allow to identify the safest pathway with a complex angle of insertion or a dome lesion and localize a specific part of the tumor for a biopsy, for example, a lesion which is active in PET or MRI. What can we fuse? We can fuse MR images. We can fuse contrast-enhanced images with ultrasound. So that's an ultrasound to ultrasound fusion. We can also use PET or CT images to identify areas where we want to treat or target. So this is an image from Dr. Solviati. You can see down here that he identifies an area on the CT scan and tries to find that area and under ultrasound. And by that, you can confirm that the area that was seen under CT is the same under ultrasound. And you can put target markers on these areas and confirm those target markers. And this will allow you to follow up these lesions time and time again with ultrasound instead of doing continuous CT examinations. Another way is a lesion that is seen under CT, and this is a contrast-enhanced CT. You can follow it up with contrast ultrasound and verify exactly the area and the margin of that lesion by doing that superimposition of images. Another technique that can be used is to identify the growth or shrinkage of a tumor. So, for example, we can co-register a lesion and from the MR and follow its size as it was and how it became after treatment. And that can identify and help us follow up and have a referral pattern on that lesion and following it up after treatment. Another tool that's very useful is the color Doppler. And with the color Doppler, you can have a correlation evaluation. And the contrast flow will allow you to correlate with the hemodynamic information on high-definition MRI and CT images. So, for example, this is the Doppler, but I can project the Doppler on the CT image and verify that these are vessels. And this precision can be assessed with this overlapping, and this is my target area. So I can acknowledge that I'm outside a vascular structure. Also, nodules are very usefully targeted by fusion imaging, specifically in the axilla where you have lymph nodes that we want to biopsy, where we can see them on the CTs. We can identify this specific nodule with fusion imaging and be sure that we are targeting the exact point that we have seen in previous imaging. So once the plane of registration is performed, it is possible to fine-tune with a manual rotation and access the lesion that was seen on the other modality. Also, in the same sense, targeting is very important because in this way, we have the ability to target a specific area and find the exact position that we want. And we have identified on the CT image. So by doing a correct registration, we just scan through the images, and that would allow us to scan through the CT and actually correlate the two and go exactly to the identified position. To do this, sometimes we need a tool which is called a virtual needle tracking. So actually, instead of seeing the needle projecting, we can put a virtual needle with the area that we want to attain. So this is the virtual needle, and this is the area that we want to attain, and this is the actual lesion. So the one and the other are superimposed and confirming our pathway. This will allow us for targeting and choosing a path prior to the treatment. You can see the virtual needle and you can see the actual needle in both images. Although this is a very useful technique, the virtual needle has some limitation, and this about needle bending and estimated endpoint. And I will explain what this means. Actually, when the needle goes inside the tissue, it follows respiration rules, and that affect its form, and there is some form of bending. So if this is an MR image of a true needle curvature, the theoretical virtual needle tracking would show the straight line and would not compensate for the bending. And that's why we need more sophisticated equipment in order to be able to calculate for this changes which happens inside the body during to movement, bone, rib cage, etc. And that's why new systems are developing, which allow, for example, here in Mindray, to register the whole 3D volume. And by the 3D volume, we can have the imaging of two needles, and the one is the actual needle, the other is a virtual needle. And you can estimate the differences between the two trajectories in order to achieve a certain endpoint. So on the left side, you can see the actual needle track. This is the virtual needle, and the red shows the superimposition of the actual needle next to the virtual needle, and you can estimate the small differences. This is very useful, specifically when we're going ablation treatments. And by this function, we can again identify our area, design our trajectory, and you have the virtual side on the one image, and you have the actual on the other one, and you can see the gas out phenomenon during this ablation. These were the lesions that were ablated, that needed ablation, and this is the final result. And you can see the ablation areas exactly as was designed previously by the physician. With this kind of technology, we can achieve a very high level of correctly targeted lesions. And this is a paper done by the group of Solviati from Giovanni Mari, and you can see that they were able to assess and target correctly the tumors at a rate of 95.5% using ultrasound, which is a very high score. Again, the same thing, the virtual needle, the true needle, the approach, and the ablation. Now, this is a very interesting aspect, is the LTP. What does LTP mean? It's local tumor progression. So sometimes when we ablate and our margins are not complete, we can have a local tumor progression in the area which has not been ablated. By using these modern systems that allows us to identify the volume of ablation, we can then retarget the area and reablate that local tumor progression. And this is the final result on the CT showing that this high intensity area here with contrast uptake has completely been ablated afterwards. In the same sense, we can now identify and create safety margins by having a safety margin, an ablation zone, an ablation margin on a 3D volume. Then we have less risk of having a recurrence in the area. So in this way, we can travel through the volume. This is the ultrasound. This is the axial imaging, and you can see that there are rings, and we can travel through those rings, showing you the maximum volume, which is the purple image. This is the maximum volume that we should ablate in order to have a good and safe margin. So ablation margins are mandatory for effective treatment. Ablation results can be evaluated now not only by CT or MR, but also by contrast enhanced ultrasound. And SEOS features better real-time performance, and 3D SEOS now collects the 3D contrast enhanced images based on the regular SEOS and creates a volumetric rendering, and that volumetric rendering can be used for fusion imaging. This protocol is called HIT, which is Ultrasound Hepatic Interventional Therapy, which segments the tumor and ablation area and automatically registers and merges those 3D images we talked about, the volume rendered data, before and after the ablation to intuitively display whether the ablation area has reached the sufficient margins that we designed in the beginning. So in that sense, these are the purple area that we want to ablate. And again, those 3D volumes are superimposed, the theoretical with the actual ablation. And you can see whether we have covered our expected ablation treatment, comparing the images with contrast before and after the ablation. In this case, for example, the purple area is the area we wanted to ablate. The red area is the actual ablation zone that we created. By superimposing the two, we can see that we have covered the lesion, and you can actually compare with different slices from the ultrasound volumetric data. On the right-hand side, though, things are a little bit different. You can see that this is the ablation margins as showed by the contrast enhanced ultrasound, but the lesion is not completely covered. There are areas of the lesion which has been untreated, and you can see here that it's not covered by the red zone. And the same thing, when we do the volume rendering, you can see that there is an area of the tumor which is not completely covered, and actually this area can be a risk for a local tumor progression. If we push the technology a little bit forward, we can see that we can now access occult lesions, which are not seen by the ultrasound. So in this case, for example, this is a pleural lesion seen on the CT. And by doing the registration, actually, we use the ultrasound to guide us to the correct target area and do the exact biopsy or treatment that we want in the area. And this is the occult lesion under ultrasound, but we trust the CT image and we actually trust the registration that shows us the exact approach in the area. This is also very useful when we want to treat breast lesions. The problem with breast lesions is that breast is a malleable tissue, and thus registration on it is very difficult. So in this case, what do? We use external fiduciaries. So these fiduciaries are actually marking the area around the lesion. And we can find those fiduciaries and then do a correct registration by now knowing the exact position of these fiduciaries. And identifying those will allow us to identify the lesion under ultrasound and do breast occult ultrasound lesions by using the fusion properties. So co-registration of MRI and real-time ultrasound enables sonographic localization of these breast lesions as described in this AGR paper. There are a lot of papers in the literature about the clinical utility of real-time fusion, which you can find a lot of data either for biopsy or for ablation or for volume navigation. And the idea is that this treatment will help us identify better the lesions and actually create an algorithm when the conventional ultrasound is visible or invisible. You can either use the fusion imaging for different roads, either for the ablation or for anatomic landmarks. So the idea is not only to do the treatments or the planning, but also it's a very useful educational tool. because you can follow up a consistent anatomy. So for education, for example, for people who want to learn musculoskeletal ultrasound, during the MR, during their educational phase, doing the fusion between the MR and the ultrasound will allow you to identify the different tendons, to identify the different nerve sheaths that you can easily see on the MR, but have difficulty to acknowledge under ultrasound. And that is a very useful educational tool for young trainees. A tool which has actually shown all the benefits of this fusion guided imaging is prostate. And with this comparison of MR ultrasound fusion guided, we can target lesions which otherwise will not be identifiable. So what we use now is the multi-parametric MRI with the definition of the lesions and do a prostate biopsy by fusioning the MR imaging to the ultrasound imaging, and thus allowing us to access areas which are highly suspicious of secondary malignancy. For example, this patient, which is a 56-year asymptomatic patient with 4 negative previous random biopsies that we could not see the area, we can identify actually the multi-parametric MRI suspicious area, and by that being able to access it, biopsy it, and actually show that there was clinical significant disease in that area. If we push the bar even further, the future talks about augmented reality. So actually now we can project the screen image in space using 3D glasses and actually see the ultrasound screen on top of the actual model. So this is reality, and this is augmented reality by projecting in glasses the area of interest with ultrasound. And if you add to that the virtual needle, then you have the projection of the ultrasound image, and the same space you can project also your virtual needle in order to see the exact positioning. And all of this can become part of what we call fusion imaging with augmented reality. If you focus in that image, you will understand that something is wrong. The wrong part is that the radiologist is looking at his screen, and the operator who's doing the intervention is looking at his hands. And this is not an optimum configuration to use the technology, because the evaluation of the position is done verbally from one doctor to the other. What you need is to be able, all of this, to integrate it into one fusion pattern. So in conclusion, it's a fast and easy to use and low-cost tool with real-time imaging and high spatial contrast resolution of CT, MRI, and ultrasound. You have increased precision, accuracy of procedures, and reduced duration and number of ablation sessions, because now you're targeting correctly and you can also supervise your margin. You have hepatic and extrahepatic applicability, as we have shown until now. With that, I would like to end. Thank you all for listening, and invite you to our annual scientific meeting, which will happen in California of SIOs. SIO is the Society of Interventional Oncology, where all of these technologies will be shown, and there will be a lot of teaching points. Thank you very much for attending this seminar.